Okay, great. Well, thank you very much. What a wonderful opportunity to be here, and definitely I feel a resonance with some of the ideas you were sharing with us just now. The opportunities that we've had in nursing and to be part of global health and outreach, particularly in the area of education and capacity building, have been really wonderful for us here at SickKids. I think in the early days when myself and colleagues were invited to participate in going overseas, working with another country to share our education based on the knowledge and skills we have here for pediatric nursing, we were kind of approached to do that in a way that was about come, share your knowledge, and it will all be fine. And to your points earlier, many of us started talking about the importance and the value of education and how much commitment we have to sharing our knowledge, but we didn't feel that just sharing knowledge in traditional ways was going to actually help us get to the outcomes that we were hoping for in terms of building capacity for our colleague nurses, for the outcomes that we wanted to see in children's health through pediatric nursing. And so we really reframed what we were doing around the concept of whole systems change, around integration across education and hospital or practical environments. And we really, I think from the very beginning of the work that we've done here at SickKids, have embraced this idea that education is a really important vehicle. We want to embrace transformational methods of education. We want to develop partnerships that are mutual, reciprocal, and offer us opportunities to co-create curriculum and to evaluate the application of that curriculum, to debrief the learnings, not only for our teams that are engaged in these opportunities, but for the educators that we're working with, because the idea of the faculty development is so important as well. And so we've really embraced opportunities for education in global child health with this very sort of broad lens, with this holistic perspective, and I think it's served us really, really well. So maybe I'll leave it there.
Yeah.
And
so I'll come back to you and specifically seek, now that we've had some experience of doing this in various geographies, Qatar, with the Ghana nursing program, is to get a sense from you as to what the challenges have been, and again, how do you see this moving forward? Let me turn to Julie and give you the floor to.
Great. Well, thank you again for inviting me and for the great talk. So I have two hats sometimes, because I work doing education in Toronto, educating residents, and now with the Global Child Health Fellowship, and working to work with people coming through the Canadian system who are interested in global health, and on the flip side, act as a curriculum coordinator for a residency program in Guyana. So it's interesting to have all these conversations when you look at the interface between how we speak about global health here and how global health is experienced in many areas of the world. And much of what occupies my time from a scholarly perspective is the discussion between the practicalities of some of the ways that partnerships and programs are developed, and how that relates to some of the questions about equity and inequity, neocolonialism, and past histories, and how those work together. So an example of this would be simple discussions about language of instruction. So, thoughts around many major academic health science centers across the quote-unquote global north practice in English, and therefore distribute programs and practices and partnerships that are centered in English. So how do we look at that from an equity lens and thinking, who are we missing when we talk about equity in education, by simply the practicality that many of the places who have the resources to impart this are doing that in a certain language. Also discussions around where are the medical schools? Where are we partnering? Who are we partnering with? So thinking not only about where we create our partnerships and how we implement all this fabulous stuff about transforming learning, but through that, who are we not partnering with? And what does that mean for global equity? And what does that mean for global education as we move forward? So some of those discussions about how the practicalities of education may be at odds with some of the goals of what we're trying to do with education, and how we're reflexive about those moving forward to try to tackle some of those barriers.
So let me turn on that note to you, Julio, and ask, these broad goals of global interdependent learning or exchange at some stage have to be married to standards and competencies. And those standards and competencies at times will be contextual. So to what extent are global centers of excellence in learning prepared to perhaps become a lot more flexible in terms of creating expectations and demands in public health, for example, that create a level playing field and not necessarily become a barrier in themselves?
As you know, from your very active membership and participation in the commission, in the Lancet Commission and the Education of Health Professionals, that was a big topic that we tried to tackle. Because you have that is the challenge of globalization, I think. In fact, the main challenge. How do you maintain the connectivity and interdependence while being responsive to local realities? How do you avoid globalization leading to new forms of neocolonialism and cultural dominance? And, you know, the big problem the world has is how to embrace diversity without divisiveness, right? And diversity means that you celebrate the fact that we're different, that we speak different languages, that we have different religious beliefs, but that we can all live together and be interconnected in that diversity. That is the toughest challenge, and obviously the world is not doing such a good job in addressing it. But we can set an example in education. I always say that the value of education institutions is we need to model to the outside world what we would like society to look like. So being very sensitive, I mean, I like very much the fact that you brought this question of language. It's something we've been struggling with the MOOCs. And we now have a very active policy. Now, that all requires resources, and it's not easy to fund this, but we've been able to start doing that, which is just the most superficial level. But then you need to go to much deeper levels of cultural responsiveness to realities. I think if one thing we've learned of the Ebola outbreak is don't just parachute into crisis situations without understanding local culture. And I think it's been an enormous lesson in cultural humility for you know, us in public health and in global health. If you don't understand local realities, you're not going to succeed, because human health is deeply ingrained in the human experience. So how do we then marry that with the fact that we do have a global society, that we do have mobility, that I need to more or less be able to say, oh, you're a nurse, you're a nurse, you're a nurse, and there's enough commonality that we are talking about more or less the same thing, right? The same competencies. Yeah. So we do come in the Lancet report in favor of a process of dialogue to develop some level of common standards. That's also important for labor mobility, the labor mobility of health professionals. You know, you and I, we're trained in a different place than where we are practicing. It's got to be some element to know that, you know, we have developed those competencies. How do we do that while being locally responsive is, I think, the key issue. And, you know, the report comes with a few suggestions, but I do think we need to figure out a way in which we have this, by the way, is also in the service of the populations in other countries. I mean, you don't want people running around declaring that they actually have a set of competencies, practicing on individuals who don't actually have that. So I do think there's a need for a common core of standards, some element of accreditation. I think this is where institutions like WHO could play a role. But then we need to give enough scope, because it is very different to practice pediatrics in the heart of Toronto, where I'm sure there's a high supply, than to be the one pediatrician in a country of several million people. It is a completely different element. And if you don't understand the difference, then you're also doing a disservice to those populations. But we gotta come. I think part of the issue is that there's a lot of the elements of that that define our common humanity that are amenable. You know, diseases. There's of course genetic variation, but there's a lot of common elements in the nature of health and ill health. And then as you move into the interpretive side of the health sciences, is when you need to be much more culturally grounded.
So I want to go back to our panel, and as you think of questions or comments, let me ask you, Pam, while people are thinking of this, what has been our experience, particularly with the nursing education program? And the two things that I would like you to address is, firstly, what has been our experience around these common standards issue? And second, sustainability of some of these endeavors.
Well, with regard to standards, that is a challenge, but it also poses a great opportunity for us. So we have had the experience when we've been engaged in a different country in a global context, that it's really important for us to meet with the local leaders to understand the professional bodies for nursing within that country, and to really dive into understanding what are the local standards that exist. There are different standards in nursing related to the education and the graduation from nursing programs. There are different standards and sometimes non-existent standards in the healthcare environment where nurses are practicing. So it is really important for us to think about, explore, and uncover what those standards are locally, and then work with them in the context, excuse me, of what we're used to and what our standards are. So we have to be open to learn and to mesh those standards. One of the things we're actually doing is we do have a team now that is actually looking at pediatric nursing standards here in Canada, so that we can develop a broad-based set of competencies that would be, they would be useful for us as we navigate these partnerships. We actually don't have standards for pediatric nursing in Canada, per se. We have standards at the Hospital for Sick Children. We have policies and procedures that guide practice. We have expectations from the College of Nurses in terms of regulatory expectations. There's standards to meet to graduate from certain programming. But we think that it would be very valuable for us to have a document that actually outlines the common competencies for pediatric nursing that we could use here and in partnership with local communities and community leaders. So the standards question is one that is evolving for us, and it is one that we're paying attention to when we're working in the local context. To your point earlier, a nurse is not a nurse is not a nurse. So it depends on education, it depends on experience, it depends on regulation. And the countries around the world are all different. I think through our global health education programming, we are moving towards more common understanding of what it means to be a nurse, what the identity of a nurse is, what the professional boundaries of a nurse are, and what the potential scope of practice of a nurse is. So I think this is very exciting, and that's why I say I think there's an opportunity, because we are engaging in those discussions and we're trying to move forward and use common frameworks to support and elevate professional nursing so that there is more consistency in the understanding of what a nurse does. With regard to sustainability, great question. I'm really proud that our team has paid attention to sustainability from the very beginning of the work that we have done. I think just ethically, we feel a strong commitment to be in partnership and not to parachute in and leave a lot of information and move out from a country, but to engage with a country a local nursing leadership group in partnership in a way that's going to be of value to them. So first of all, in developing sustainability, we are paying attention to what are the needs. We're co-designing programming. We are working with the communities in partnership to identify who are the local leaders, who are the local educators, who are the local physician champions and partners who can work with us so that we can all be understanding what the goals of our program are, how we can shore up the systems, the processes and practices that are in place and where we're working so that we can make changes to policy or standards locally that will support the education. And we've really felt that it's important to pay attention to the capacity building of the educators. So either working with individuals who are educators when we start, or identifying where there's actual gaps in the system and there is a need for a role for an educator, for example, for a nurse educator to be built into the infrastructure of the system, who will be able to continue to understand what the needs of the nursing team are and to build education in an ongoing manner for professional development. We've partnered with the academic institutions as well and supported capacity development for not only curriculum development and program delivery, but also for research. And that's an area I think that in terms of our global health work, there's a real need and a desire for nurses to become more familiar and more competent in the area of research. So we've been trying to pay attention to that as well.
That's a great point, and I'll come back to this. But let me go to the floor and just introduce yourself kindly and go ahead.
Hi, thank you very much for the thought-provoking discussion. My name is Emily, and I'm a summer student here. A question that came up to my mind is when you're educating health professionals abroad, how do you approach dealing with very traditional cultural practices that might not necessarily be the Western understanding of like the best practice or the best hygienic practice, and how do you reconcile this tension in a culturally sensitive way?
Judy, you want to take a crack at this?
Sure, I love that question.
Yeah.
So thank you. It's
a great
like it's right in my alley. And I think it's an excellent question. I think we have to examine our underlying bias when we go in, that our practices are the gold standard. So when we're educating across the world, we have to understand that there's many ways to deliver medicine, and there's many areas of health, and there's many ideas of what consists of health. And not only is the pedagogy of medicine and the way we teach medicine different across the world, but the way that medicine and health is perceived and received is very different across the world. So I think part of the way that we get around that is to be very reflexive in terms of what our goals are in developing capacity building through education projects. And if upon thought our goal is to come and bring our education somewhere else, then perhaps we need to think about how we reframe that in terms of true capacity building, which is using the local infrastructure, the local medical practices, and helping to enhance that in the same way that at home we continually try to enhance our own medical practices. And thinking about what they have there and what we have here and how together we can move forward in terms of enhancing health. So, and also learning, I mean, there's a lot of examples of where Western or medicine and more resource rich areas have learnt from partnerships in less resource countries. So being open to how these opportunities can help us practice medicine better here. I think many people would agree that practicing medicine is, only a small part about what you read in the textbook. And to truly heal and practice medicine, it's my feeling that you have to understand the context of, for me, the child and the family, their beliefs that they bring in and how they heal and what is important to them in healing. And that's how you're going to be able to increase health. So not only from an individual point of view, but from a community point of view, it's very contextual. So being able to tap into what the context is.
And I'd just like to add to that, Julie, because I think one of the things we've paid a lot of attention to in nursing is the focus on strengths and using an appreciative approach so that we can actually understand deeply, listen to, and work with our partners to achieve education that's going to be meaningful and that resonates with them to improve the goals that are important to them for the health service they're trying to deliver. So I think understanding culture is something that we have to pay attention to every single day and challenge our own assumptions about why we're doing something the way we're doing it, why we think what we're offering is the best, and have enough humility to pull back at times and think there might be a different way to achieve an outcome. And we've done a lot of reflection as well as debriefing with some of our educators who've been engaged in global health education, because there is a lot to learn for us, and this idea of culture and sometimes moral distress that comes to the forefront right at the practice setting when things are different, when beliefs are different, is something that we do need to pay attention to and begin to sort of uncover and find the way to navigate that.
We should. Oh, sorry.
Yeah.
Did you want
Go
to? I
ahead.
was just going to say we should mention that there's again this practical aspect. I mean, to go back to your question, I mean, there are instances where we can say that there's universal truths in some parts of medicine, such as antibiotic use for disseminated infection or chemotherapy used for malignancies. So, and there are many places where traditional healing is used to combat some of the medical conditions that we would feel that there is a universal truth in terms of treatment. And I think that is when the cultural humility also takes place in terms of being able to accept and partner with and work towards finding a means to treat effectively. So it's a little bit of balance between, I think, the conceptual ideas of how we work together and the practicalities of, causality and what we do use to treat and how you bring those together.